So hopefully you enjoyed the morning conversation on behavioral health. This is what I've called the good news panel next. They're going to lead us through some very positive conversations around our financial sustainability in healthcare. So if I could start by introducing our moderator. Ryan Witz is, first of all, just a great individual, but Ryan is a seasoned healthcare finance executive with more than 15 years of experience in Medicaid policy and reimbursement. He's served in a lot of roles. Currently, he is the executive director with the District Hospital Leadership Forum and a senior manager at HCAI Consulting. So Ryan, if I could bring you up, please.
Well, it's a pleasure to be here. Thank you so much, Demetrius, and for you all really suffering with us for the next 90 minutes in advance. We are the good news panel, I guess, as Demetrius framed it, but it is a pleasure to see you all. Ryan Witz, Executive Director for the District Hospital Leadership Forum. We represent the 33 district hospitals that cover the state of California, and I see some district hospital faces in the room, so great to see you guys. I'm joined by an amazing panel. I'll let them do their own introductions here in a second, but wanting to set the stage a little bit. You know, it is not lost on any of us and those who represent hospitals across the country, but especially in California, that we are all going through some very difficult times. The uncertainty is mounting, and it is attributed to a variety of things that are even out of your control. We recognize that. From regulations, from cost inflation, from workforce challenges to requirements for capital investments, et cetera. The list is long and it continues to mount. And I know we have a panel later this afternoon who will go through a lot of the solutions for these problems, but we're going to be just level setting with some of the challenges we're all facing. So we have seen collectively the risk of hospital closures grow at a higher rate, especially over the last few years. So our goal today is really to do our absolute best to underline the pressures, identify the pressures, and then also just discuss what we're seeing as potential opportunities and how to respond. We may not have all the answers. You're not going to walk out of here smiling with a list of here's exactly what to do, but we're going to do our best to at least identify those issues, and we're going to kick it off. So I'm going to ask Adam, Mr. Dorsey, why don't you kick us off with your introduction and maybe some opening remarks?
Yeah, so my name's Adam Dorsey, and I am kind of a Sacramento animal. I moved out to Sacramento after graduate school, and that was 19 years ago, and worked in trade associations, and then I worked in state government. Most of that work was for the Department of Finance, which is the state's equivalent of the White House Office of Management and Budget. And so I've spent my whole career working on healthcare issues in the state capital, but mostly around fiscal policy. And so we're going to be talking today about sort of the bind that we're in between a federal government that's trying to crack down on reimbursement for hospitals and a state government that at the moment's not very well equipped to kind of respond to some of those challenges. And so that'll be the focus of my remarks.
Eric.
Hi, I'm Eric Lucas. I am the National Practice Leader for Hospitals and Health Systems for Baker Tilly, formerly Moss Adams. I've been in this role for a pretty short time. Before that, I spent about 20 plus years with Dignity Health Common Spirit, running their revenue and reimbursement group. I have been spending the last couple months having a lot of very interesting conversations with hospital leaders across the country about a lot of the changes that are taking place. So I'm hoping to contribute a little bit to the conversation from the perspective of what we're hearing. I've done a couple of these panels. They've never been positive.
I'm going to change that today.
I was asked to moderate one a week or two ago, and I had pictures of puppies and kittens behind me the entire time to balance it out. So,
Felicia, please.
Hi, I'm Felicia Z. I'm the managing partner of Athene Law, which is a boutique healthcare firm that I started 7 years ago. My practice focuses on healthcare reimbursement and compliance. We do work with, a little bit different. We don't just work with hospitals, and I know we have some medical group folks and some FQHCs here in this room. So we work with a panoply of providers, which I think is helpful because we get to see the trends across different provider types. We also do work with about 10 or so provider associations, hospital and other provider associations based out of Sacramento, which I think also, I'm not quite in the weeds like Ryan and Adam, but it does help keep me up to date on those issues.
Well, thank you, Felicia, and thank you, Eric and Adam, for, buckling up for the next 90 minutes. So we're going to start with just the level setting and Mr. Dorsey, if you'd be so kind to kind of share the state of the state as it relates to kind of our fiscal outlook and how well we're positioned to really solve the challenges that are coming our way.
Sure. So I think that with all of the problems that we're sort of being faced with at the federal level, I think that a lot of the kind of initial response that we get is, well, the state will have to step in and backfill this lost federal revenue. And so what I'm hoping to do is just kind of paint a picture of where we are and kind of how we got here in terms of the state's fiscal condition. The state was experiencing kind of a obscene surplus following the COVID pandemic. Revenues were exceeding sort of estimated by scores of billions of dollars in 2021 and 2021-22. And there was a lot of pride being taken by the governor at that time to say, we've taken these record surpluses. And the surpluses were kind of twofold. One, it was money that was, unprecedented stimulus being added into state and municipal government from the federal government as a way to kind of stabilize the economy and stabilize government finances because, at the time when the pandemic hit, I think that a lot of us thought the world was ending. We thought that we were going to have an economic collapse. And so the stimulus that the federal government put in at the time far exceeded even the stimulus that was unprecedented at the time of the great financial crisis. And that money created state government surpluses that the state has never seen in its history. It made the shortfalls in 2008 really kind of pale in comparison to the overages that were happening in those 2 years during and immediately following the pandemic. And there was a lot of pride that was taken at the time when kind of final budget agreements were announced in those years to say, well, look, we're being so responsible. We're spending 85% of this discretionary surplus on one-time issues. But that meant that they were spending more than 15% on ongoing commitments. And when the stimulus ran out and we kind of went back to sort of normal economic growth, we were left with what I like to kind of jokingly refer to as a structural deficit from now until the day after the world ends. The state is facing budget shortfalls of between 50 to, now the LAO is saying yesterday, could be growing up to $35 billion a year. And so there's really no plan to address that. And what's happened is that the stock market continues to set records, although you can set aside this week so far. But generally speaking, we're on an absolute tear. We've had stock market returns of 18 to 25% growth over the last few years. Historical average is around 8% a year. And yet the state's got a structural deficit that is, quite sobering. And it's because expenditures have far outpaced this record revenue growth. And unfortunately for us, a lot of that expenditure growth, in fact, almost all of it, has been in health and human services spending. So the biggest sources of general fund growth over the last couple of years has been spending on childcare, spending on developmental services, but really, and that's kind of on a percentage basis, but really most of the dollars have been Medi-Cal commitments. We have a lot more older adults on the program where you've got the lowest amount of federal match and they're the most expensive population. A lot of that's driven by policy decisions like eliminating the asset test from the eligibility rules. And then you've got the expansion to the UIS population. Really good policy goal, reducing the amount of unemployment and uncompensated care costs for hospitals. But it was really done without a fiscal plan at the state level to actually pay for it. And that's where you have kind of a boom and bust sort of Medi-Cal program in California that kind of mirrors our revenue structure. Governor Brown thought it was really important to create a rainy day fund. Passed Proposition 2, created a rainy day fund. Despite this really very strong stock market that's led to very strong state revenues, the state has spent down that rainy day fund, which means there's not really general fund reserves anymore. The plan in last year's budget was that the governor would release the January budget here in a couple weeks now with a projected negative $1.5 billion in general fund resources. I think that we're all sort of accustomed to the federal government running these unbelievable budget deficits that just kind of like no one even can fathom the numbers. And so you kind of have this assumption like, oh, governments can just kind of run deficits and we'll just kind of address it later. State governments are a lot more like our checkbooks. They don't have the option of controlling monetary policy. They only have fiscal. So at some point, when the money runs out, you've got to pay the piper. And there's three ways that states can balance budgets. It's new revenues, it's cutting expenditures, or it's gimmicks. And I'll put in that it's really gimmicks are a form of borrowing. It's doing something that you know you can't realize today, knowing that you're going to have to pay for it tomorrow. And it's the same concept as borrowing as well. And so that's the position that we're in at the moment, is that they've already started with the gimmicks. Last year, there was an overage in the Medi-Cal program of $4.5 billion in general fund. And instead of paying for it last year, they said, oh, well, we're going to borrow from special funds that are committed for other purposes, and we'll repay the special funds in 10 years. This is the kind of gimmicks that we did in the depths of the economic crisis in 2008 through 2010, but we did that because we knew that the economy was going to grow. We are at what might be kind of lofty AI bubble levels at the moment. It's unlikely we're going to grow out of this situation, and the state is reducing their flexibility to solve for a potential economic downturn in the future. So the state is in a bit of a pinch, and it's kind of this man-made pinch of tough budget, and it's because of decisions that were made at the state level. And so as much as we would like for them to be in a position to help us right now and to help the hospital field right now, it's going to be challenging for the next few years.
Just unpacking that a little bit further, how you paint a very real picture. I don't know how else to put it. How well in your opinion, are we positioned to solve some of the problems that are presented at the federal level with the Medicaid cuts, or potential recession that's coming with an expansion of the Medicaid rules, which is always countercyclical to state budget. It's always the challenge that we have. I mean, how well, in your opinion, are we positioned?
So in a lot of ways, we're better than the Great Financial Crisis, and so I think that that's a really good prompt to think about this in terms of not being too negative. The state has Well, first of all, we were able to put off cuts over the last couple of years because of the rainy day fund that Governor Brown created. And so thank goodness that money was there. That account had, over $40 billion in it a couple of years ago, right? So it's being spent down now, but at least we had those resources. The other good news is that, in the great financial crisis, the state had a cash problem. We don't have a cash problem today because of the healthy balances that remain in the special funds right now. And those are borrowable resources for the state. When we were going through the great financial crisis, the state was running out of cash. It was unclear in some months whether the state was going to make payroll for state employees, whether you were going to be able to make managed care capitation payments in the Medi-Cal program. We're not in that position right now. The problem is that we're running into a situation with the general fund resources running out. If you keep borrowing, then you're creating a problem later that has to be repaid, and that's the problem that we're in. And so there are aspects of the situation at the moment that are much better than they were during that period. And the other thing that I'll say is that revenues continue to really outpace expectations. In the current fiscal year, only through the month of October, so 4 months into the fiscal year, revenues to the state government have exceeded expectations by $6 billion. We finished last year $2 billion higher than we thought we were going to. And so that has also kind of created just enough room to kind of have the governor be able to think about options. The problem with state of California, of course, is like we've got these initiatives that really tie the hands of the legislature to solve these problems. And so most of these overages in state revenues are actually going to go to schools. And because, we're going to talk more about this, I think, later, but, on the expenditure side, a program like Medi-Cal, you do an estimate of what you think it's going to cost to run the program, and that's kind of where you start for next year's budget. Schools have the opposite situation in California. The schools budget, and schools are the biggest expenditure for any state government in the country. The schools budget is based on a formula that's based on how much revenue is coming into the state, so it's sort of flipped compared to every other program in state government. They get a percentage of the revenue based on formula, and most of this revenue overages that we're experiencing so far is not going to be able to help the state budget because it's going to go to the schools for technical reasons that I do not understand because I'm not an expert in education.
Yeah, no, and it's definitely a challenge as we wade into the reality that HR 1 is going to create. And so much of our Medi-Cal program, last question for you, really hinges on Medi-Cal supplemental payments, which have long offset the obligation of the state general fund intentionally, right? Provider taxes, intergovernmental transfers, insulated the responsibility of the state. I'm just curious, is HR 1 and the risks that are proving presented are going to start to constrain that? Are you envisioning that we're going to have to reshape the way we finance Medicaid?
Yeah, there's no doubt about it. And I know that we'll talk a lot more about this, but during the great financial crisis, we really got the state general fund out of the business of providing rate increases to hospitals. Rates were not good back then, but there was the California Medical Assistance Commission that would set per diem rates, and the rates were paid by the state. We ended up with what, at least temporarily, kind of became a bit of a win-win. We got hospitals a little bit more money by funding and financing their own rate increases through the provider tax programs and other similar self-financing mechanisms. And it also provided a cut of those revenues for the state general fund. The way that the budget worked back then, it was so bad and so dire that the state would come to groups like the hospital industry and say, well, how do you guys want to take your cut? We're going to cut you. We're going to have some piece of your revenue for the state general fund because everyone's got to play in solving this problem. And so by using something like the hospital fee program, you get 24% of the net benefit of the program. That goes to the state budget, and the rest of it goes to hospitals to fund increases that otherwise the state would have not been able to afford to provide. And so, everybody kind of won except for the federal government, and now the federal government is saying
Enough's enough.
Yeah.
Yeah.
Exactly.
And it's going to force us to reshaping, the hospital fee program and other provider tax programs as well. Eric, just in your experience, obviously many years, even seeing the establishment of the hospital fee, being on the earliest work groups, designing this provider tax. Just curious, in your experience, how does that really shape kind of decisions that are being made within your organizations that you work with or had worked with in the past, and the substantive delays that we just continue to have now with this new regulation?
I think it's giving me a little bit of deja vu.
Yeah.
When the program first came out, I think I was on the phone probably with a few people in this room talking about this great program that was going to bring dollars in. And I got a lot of sure, that's definitely not going to be happening. And the delays that we got from CMS to approve those early ones, and then figuring out with our accounting firms how we got to record these things when the cash wasn't going to come for a while, the whole process had a great deal of uncertainty to it. But the promise of it, the fact that we were going to be funding our Medi-Cal increases when there was always uncertainty as to where that money was going to come from and whether it was going to come. I know the preceding years they had capped rates multiple times. So we really were watching Medi-Cal reimbursements decline and decline and decline as it related to cost. The provider fee program actually gave us a lot of promise. But it took a few years for us to actually build confidence in that, to where we were actually putting it into our budget, to where we were actually making strategic plans around it. There was still a concern that at some point the federal government was going to say, okay, this program's way too big. We need to pare this back. After about 4 or 5 years of that, and the accounting firm saying, this looks really great, let's go ahead and record it, I think the thought changed and the confidence changed, and I think the comfort with these additional dollars changed. I think what was really interesting at the time, probably about halfway into the program, I started to have CFOs coming to me and saying, correct me if I'm wrong, but Medi-Cal's now actually a really good payer. When I take a look at the rates I'm getting and I take the provider fee and add that to it,
right?
Yeah. It's not a bad payer. We spent years going, oh, my payer mix is bad because Medi-Cal is high. And then all of a sudden it changed to, no, it's not so bad. This program, not only do I get the dollars from the provider fee, but it's influencing my Medicare dish rates, might have got me a 340B into the 340B drug pricing program. This is not necessarily a bad program. I think now, as we start looking at these cuts, and if we're going to talk about those early design days of the provider program and the arguments and what those things look like, that's certainly fine. But I think it's going to be extremely complicated to address the HR1 concerns in the current mechanism, and I think we're going to be looking at a Medi-Cal program that doesn't necessarily look like those olden days, but will look a lot different.
Well, I mean, how will hospitals have to respond to that, I guess, is really the question that these folks probably are having is, if I'm going to be weathering significant reductions in reimbursement, obligations aren't necessarily changing on our organizations. I mean, in the past.
These are, a couple different things. You're taking a big block of revenue out. So there's not one thing to do. This is, you could probably try to cut to balance and reevaluate your service lines. You could find other ways to fill that hole by changing payer mix. There's going to be a lot of different strategies here, but the fact is there's going to be a hole blown into the income side of the income statement, and somehow there's going to need to be a response. And it's going to be different for everybody because, of course, some are far more reliant on those additional dollars than other providers.
We're going to do everything we can to ensure that the new regulations and the new requirements, we can adapt to it. But maybe Felicia, you can share your perspective on whether that is even sustainable within the current structure that we have today. If it is passing the current federal test, will change need to be happen just to maintain that funding level? And any other thoughts you have?
Yeah, let's take a quick step back because it sounded a little bit like it was going to go away altogether.
Oh yeah, I don't want to.
And that is not.
Thank you. No, I do not want to.
That is not what we anticipate.
It's changing.
It will
It's
change.
going to change.
And with change, there's always opportunities.
True.
But there are always risks.
Yeah.
So for those of you who are not familiar, we have a number of healthcare-related tax programs in California where there are fees or taxes assessed on healthcare entities or services that then go to fund the state share of Medi-Cal. So the first one, I think, was the skilled nursing facility fee that's only imposed on independent, non-hospital based. And then we have ICF, and then after that came hospitals, and then I think was MCO first and then GEMT, ground emergency medical transportation. And they're all structured slightly differently. But even as we started looking, and this goes back to, in when we started the early days of HCAI, it was coming on the heels of 2008, where there was the 10% across the board reduction, and then 2009, when we had the 5% and 1% reduction, which we thought was something of a victory off of the 10%. And it was out of that, it was part of the negotiation around that HCAI was born. This was a long process to get all of the players in agreement, just like it is with any of these fee programs, to make sure that you're sort of balancing the interests, because there are a lot of policy interests when you're looking at a program like this. And part of what we did, the fee had, the HCAI in particular, has certain reduced, it has different rates on different things of what gets assessed. One of the things that's different is there is a different rate that's assessed on Medi-Cal units than there are on non-Medi-Cal units. One of the things that was passed in H.R. 1 this year is that there was the Congress addressed a concern that the taxing of Medicaid units at a higher rate was inconsistent with federal policy. And with that, they imposed a requirement that you can't do that anymore, which requires both for the MCO tax, which we know, and I expect this afternoon's panel to speak a lot more on, and with the HCAI, they both have that feature. And it's fairly central to the way that they are structured. Congress did give CMS the ability to do a three-year glide path, as we talk about, to implement this, because it requires so much change. And anytime you're changing these programs, we're talking billions of dollars. It takes a long time to think through how you structure these programs. So there was guidance that came out Friday. And on this issue, which we call the redistributive issue, because I'm a lawyer and I have to use big words that don't have any real meaning. On the redistributive issue, it appears at present that the MCO tax is going to be good through June 30th of 2026, and that was the Prop 35, and that HCAI is probably okay until June 30th, 2028. Now, there's going to be more CMS guidance that comes out, because when Congress was considering H.R. 1, CMS also had a proposed regulation that would have addressed the same subject. We hear that as of, I think it was Tuesday, my week is getting a little mixed up, that rule is now before OMB in final form. But given the timing of that, we have the CMS guidance coming out last Friday, and then we know that this went to OMB. We suspect that it's going to look a lot the same, that you're going to have this, another year glide path for the MCO, and then hopefully until 2028 for HCAI. And what that means is there's going to be a rebalancing of how this works, both in terms of how much fee is paid, but then there's also going to have to be a rebalancing in terms of how the payments are made. The other aspect that I have not yet mentioned is that there is also then, over time, there's going to be a ratcheting down of how much can be collected through these fee mechanisms. And so there was guidance. The guidance on Friday stated that, well, I distill it as for the future HQAF programs, there was a suggestion that on the managed care side, we could go up to ACR, which is average commercial rates, which would have been a significant increase in that program. Because of the timing of different things, it looks like that may not be in the works. It may be that we have to go back down to the level that we were for the 2024 program for 25 and future. And that depending on the percentage, all of the fees in California are then going to be subject to a reduced percentage of net revenues that they can be applied. But a lot of that, and other folks here know the numbers far better than me, sometimes it won't even come up. So like GEMT QAF, we had set it originally at 5.1%. It's already below, I think, 3.5%. So it's not even going to be affected by those changes. And so a lot of the devil is in the details. Also, those reductions coincidentally don't start until after midterm elections. So, there's that as well.
So, yeah, go ahead. Yeah, I mean, unlike GEMT or long-term care, we obviously have Prop 35, Prop 52, which have solidified and protected these provider tax programs for years, right? Just curious as to how nimble they can be within their current structure for us to adapt to the changing landscape, in your opinion.
So there were flexibilities given in both statutes that will allow for some amount of change. The question is going to be how extensive those changes need to be. For HQAF in particular, any changes need to further the purposes of the Act. And fundamentally then the question is, what were the purposes of the Act? Was it just to enhance reimbursement for Medi-Cal and to comply with the federal rules? Or was there something else about, sort of how we balance those pros and cons between different systems or different hospitals? Is that fundamentally part of the purposes of the Act? That's a legal issue I'm not going to opine on here. So the short of it is that there is flexibility. Okay. It's a question of how much.
Well, and we know that the enactment of the hospital fee program also provides a significant amount of resources to solve some of the state general fund pressures that have been occurring. So it's in the state's interest to make sure that we're adapting our current program to the new changing landscape. The MCO tax, to the extent that there is the ability to make changes, we shall see. Adam, just coming to you, putting your finance hat on a little bit, as these income streams, not only obviously you've touched on the deficit, structural deficit that is a challenge, but as these types of programs start to risk new investment, right? The hospital fee, we intentionally wrote it as 24% that supports children's coverage, right? As those types of income levers start to either get adjusted or put at risk, I'm just curious, what response will the state have to maybe potential coverage changes, et cetera?
So we talked a little bit about kind of at the state level that the state's got revenues, expenditures, and borrowing or gimmicks. In terms of managing the Medi-Cal budget, there are kind of three main levers that drive costs in any entitlement program. And that's the eligibility of who's eligible for benefits. You've already seen last year in the state budget that was a lever that the state was willing to pull in order to reduce costs in the program. They're reducing coverage to the UIS population in the Medi-Cal program and effectively cutting people off of coverage by freezing enrollment, by adding premiums, which will result in churn in the program. The savings there is not really in collecting premiums from people, it's from reduced enrollment in the program. And so that's one. And that was a lever that was not available to the state in the great financial crisis because the federal government placed what's called a maintenance of effort on eligibility when the ACA was implemented. And so the state was dealing with a budget deficit, but the federal government said, well, you can't touch eligibility. So that left the other two legs of the stool, which are payment rates to providers, Felicia mentioned the AB 97 10% provider rate reductions. So during the great financial crisis, that had to be a lever that the state pulled. I can't take eligibility, so I've got to come after provider rates and cut provider rates. So that's the second leg of the stool. The third leg of the stool is benefits. And so you can, there are benefits that are required under federal law in a Medicaid program, and then there are optional benefits. And so I think that pharmacy is actually considered an optional benefit under federal law. So you could take away coverage for prescription drugs as a state Medicaid program. In the great financial crisis, we eliminated dental coverage for adults. It was probably the most controversial benefit reduction that the state did at that time. But there were others that were controversial as well. And so you've got that three-legged stool of eligibility, benefits, and provider rates. The state cannot adjust significantly Medi-Cal costs that are such a significant driver of the state budget deficit without pulling one of those levers, and none of those are easy decisions. The state has added quite a bit of benefits in the last few years. So I would look to that, being one area where we could see reductions in the future in order to, address the state fiscal condition.
It's definitely a risk, and I think your point earlier about just the immediate budget decisions with the undocumented freeze in last year's budget is probably a warning shot to everybody that other changes are coming, for sure, which will likely lead to higher coverage losses, right? More people uninsured. So Eric, from your perspective, these individuals in California are still going to need coverage. They're still going to need services. They're still going to show up to the emergency room. They're still going to show up to these providers. I'm curious on your reaction to that potential growing risk and pressure.
It seems like we're starting with Medi-Cal's the interesting one, right? It's usually we start with the ACA and then kind of move and watch them bounce around from one to make sure that we can get the coverage issues. But I've said many people in this room probably remember before some of these expansions happened. You bring up the emergency room. I think hospitals that don't have a good clinic system or a good mechanism to keep individuals out of the emergency room might find that the loss of Medi-Cal coverage, loss of affordable care coverage is going to result in some of those same things that we saw before, where we see individuals coming back into the emergency room a little sicker, a little with more needs, and ultimately putting a lot more pressure on the systems and ultimately hurting, from finding coverage. So there probably will be a need to return back to some of the coverage gaps that we had before, some of the other coverage solutions at the county level or other levels to make up those differences.
Yeah, Felicia, on that point, just curious on your take on, are we going to be reverting back to the 17,000 days a little bit?
I think that's probably one of the most obvious places where we go. If folks either don't want to pay cost sharing and stay on Medi-Cal, or otherwise, because of work requirements, no longer qualify for Medi-Cal, they're going to be uninsured. And the laws, Welfare and Institutions Code Section 17,000 is still on the books. Earlier on in my career, I was negotiating contracts or litigating against counties to get them to pay for emergency services that were rendered to the uninsured population. And then that went away with the ACA, right? We didn't have it anymore. You saw the uninsured rolls go down significantly. I think as we see folks going back to the uninsured state, we're going to see two things. Number one, we're going to see them going to the emergency room for care. Number two, we also have a much higher level of required financial assistance and charity care policies now in California with the legislation over the last 5 years. And so then hospitals are going to be looking at whether this qualifies as charity care or discount care. And then on the other hand, thinking about pursuing reimbursement from counties for that emergency care. Luckily, I understand that most of the hospitals in San Diego County have existing contracts with the County of San Diego for that indigent care. And so they have a reimbursement mechanism that they can revert to, but it's one that hasn't been used for a long time. And a lot of counties haven't continued to fund that because it hasn't been a need. And so it's going to be a challenge that hospitals and counties and other healthcare providers, so like the FQHCs, are going to have to work together on to find solutions.
So we're going to have pressure at the state budget. We're going to have pressure with the county budget. We're going to have, pressure on provider tax revenue and these Medi-Cal supplemental payments. A lot of pressures mounting up, which is definitely a challenge. Now, unlike maybe 10 years ago when the ACA was getting expanded and there was a lot of coverage expansions, the reality of the situation was we didn't have this thing called the Office of Healthcare Affordability on the other side to help kind of, stand up and regulate providers and payers, et cetera. Now I'm going to pivot to Adam on this one, and it's a loaded question, obviously. In events where we are seeing restrictions on costs over here, I know the Office of Healthcare Affordability has obviously pushed back and said the cost shift isn't real, right, according to their economists. But I'm just curious on your take. Will they make adjustments? Will they pivot? Will they have any response to this growing crisis?
So we're in an interesting time because, affordability is sort of the buzzword in politics right now. And that's true at the state level and it's true at the federal level. And that creates an opportunity for kind of like this simplistic view of what affordability means and kind of this very challenging environment where, hospitals have become an easy target, and the Office of Healthcare Affordability kind of has a very, tunnel vision and kind of this focus on hospitals, and without too much thought about kind of what all those drivers are for kind of the pressure on hospitals that drive those costs. And so, they are earnest in their belief to want to address the affordability crisis, but not as thoughtful about kind of hearing input about kind of what a rational sort of solution is to that. And so certainly at CHA, been, pursuing all avenues available to try and have a more thoughtful conversation about that. And I would say that if there's any glimmers of hope, it's twofold. One, that at least there is acknowledgement now recently from administration officials in Sacramento that hospitals are in trouble, that this is not a good time for hospitals. That there are hospitals that have closed or are at risk of closure. That's kind of a new development. And so I would say that that's a positive sort of shift in tone from the administration, even if it's relatively quiet and those conversations are not necessarily as front and center as we like. And then, we're not too far off from having a new governor, and we don't know what a new governor's sort of, priorities, or I guess not even priorities, but sort of approach will be. Will there be a healthier approach and dialogue in a new administration? And so I think that that's the other piece that we have to look forward to and to try and influence.
I was trying to pick out whether or not there was the willingness to allow for the commercial revenues to grow at a higher rate to offset some of the losses, but did not hear that. The tone may be changing and recognizing some of the hospitals, but I'm curious, Eric, what you're seeing on the ground floor and on some of these kind of planned provider relationships that are as a result of the office.
Well, I for the most part, what I'm hearing, especially from the plan side, is don't look at us. I know that's not I'm generalizing here. I'm sure that it's not a across the board thing, but the overall concern is as we make cuts from all of these different areas, we're going to get back to that place where we go to the employer plans, the commercial products, and say, okay, now we got to make up this difference. And for those of you who were around before the Affordable Care Act, that's actually what spurred the Affordable Care Act, those kind of discussions, because the growth year over year of those commercial plans was double digit for the preceding years. And so, but we're already kind of seeing that now. I mean, the last 2 years have shown, again, those bigger growth. So something clearly still needs to be put on the table. But the fact of the matter is, I mean, despite the concerns about cost shifting, we're taking dollars out of Medi-Cal. We're taking dollars likely out of Affordable Care Act with less coverage. We haven't talked about Medicare yet.
No.
So there's revenue coming out of this, and somehow that needs to be shored up.
Are you seeing anything, Felicia, from your interactions with clients and the plan provider kind of community with the influence of OHCA in those discussions?
So consistent with what Eric's saying, the plans are very much just saying, don't look at us, or they've been, I mean, they're not going to say that we know there's been antitrust litigation, but they've been saying across the board, no increases above the OHCA limits. Mm-hmm. Sometimes they're setting percentages that are below that. Yeah. But I think it's important for every hospital or every provider to really be looking at your individual circumstances. Because, for example, if you haven't renegotiated rates for, 5 years, your rate likely hasn't kept up with the growth of your costs. And there are exceptions in OHCA for things like labor costs, which have been increasing more than that 3%. And so we have, with pushback, we have seen more flexibility, right? It comes out as an edict, but there is movement there. The other thing on the commercial side, and I'll note real quick, is that we're also seeing increased levels of denials and delays. And that, if you have, it is easy to say, you know what, it's a $1,000 claim here, it's a $10,000 claim here. We're not going to go and appeal every single one. But at some point, that kind of gets worked into, that goes into your rev cycle practice and has the long-term impact on your organization. And so having a good strategy to really continue to push back on that, I think, is really important.
Yeah. From the association perspective, curious, Adam, just one last question on this topic. What is the right approach, right, from an advocacy now that we're seeing the writing on the walls with a lot of these cuts forthcoming? I'm just curious on your take, and if you're seeing anything, it could be a shining example.
I think that one of the things that's been really successful are, the regional hospital associations, I think, have had wins, so here in San Diego County, Southern California, as well as the Hospital Council. I think that that partnership has been really, really effective because, like we mentioned, I mean, there's county pressure, there's state pressure, and there's federal pressure. And so making sure that pressure is kind of applied at all levels of government has been really effective. And the other thing that I would say is, kind of a consistency of message, and that we're all on the same team. You can't kind of, guarantee outcomes, but you really can increase your chance of success when you've got a coherent message with your brothers and sisters in your field. I have seen, being on the state side, when you've got one part of the field kind of saying one thing and it's inconsistent with the rest of the field, it is so easy for a policymaker to throw up their hands and say, oh, well, I don't know what they want, so moving on. There's a very, very short window to get your amendments done in a bill or get something done in the budget process. The legislature complains constantly that the May revision is released on May 14th, and then they've got to have a final budget pass by the end of June and the governor to sign it by the beginning of the fiscal year. It's not a lot of time to get things done across all of state government, of which we're concerned with this little slice. Attention is at a premium. And if you are unorganized, if you are kind of off message and not coordinated with the rest of your field, it's a great way to get nothing. And so I think that working, and so of course easy for me to say working for the hospital association, but working through your associations and those relationships are really, really important, because not everyone gets everything that they want. That is always true, especially in government, but it's the best way to get as much as the field can get.
Eric, you kind of teased a little bit. Thank you, Adam. You teased a little bit about the Medicare changes. I mean, before we move on to kind of solutions, are we doing that in this hour? I don't know. It would be great to know kind of where we stand with some of the Medicare changes that also are occurring.
I'll start off with the good news.
Okay.
Because there is some good news, which was the big concern. I don't know if you're aware, but the HR 1 had triggered a potential increase to sequestration cuts to Medicare, and those could have been pretty catastrophic as far as the size of them, and that has been averted. So while sequestration that's currently in there is not going away, it's not growing. So that's some positive news. However, the Medicare side still is seeing a lot of areas of additional reimbursement change. I think the first one was recognizing that CMS is looking at pushing more or incentivizing more dollars out of the hospital into more ambulatory settings. They're slowly, over the next couple of years, getting rid of the inpatient-only list and opening up to happen more of that activity to happen in ambulatory surgical centers. So we'll see, and then that's going to be happening immediately. They've expanded site neutrality. And I don't think this is the last time they're going to be expanding site neutrality, but the site neutrality will, when this thing is finalized, was it finalized today? Was it? We're still waiting for CMS to finalize it. Yeah. As proposed, drug management will be under site neutral payments. There's still a lot of concern that the MedPAC recommendation for site neutrality will ultimately win the day. This was probably the lightest of it, but I've spent the last year talking to hospitals who are trying to preserve their 340B status because of all the fluctuation with their Medicaid days, and they've created, they have these oncology programs where there's infusion in their clinics, and now we're looking at massive reimbursement declines in those programs through Medicare. So there's a lot going on. There's also going to be an expansion to price transparency. So there'll be more Medicare Advantage information that's coming through. So that's going to certainly change a lot of the Medicare Advantage contracting discussions, which are already changing because of all the problems that we're seeing with relationships between those plans and providers and the way CMS is looking at those particular plans and their growth.
Yeah, what are you hearing, Felicia, in the Medicare space? Any other changes coming or any risks that we should be tracking?
Well, we're seeing changes in sort of the Medicare managed care space. So we didn't talk about this in prep, but for example, DHCS announced recently that there was going to be a moratorium on PACE, which combines both the Medicare benefit and the Medicaid benefit, and that's significant to show a chilling of sort of their investment there. With respect to Medicare Advantage, there was a policy announced last week from a large Medicare Advantage plan that would really chips at the idea that Medicare Advantage plans are supposed to cover the same level or scope of services as Medicare fee-for-service, where we have the 2 minutes rule under Medicare fee-for-service, and if you meet the 2 midnights, you're supposed to be paid an inpatient rate. There's at least one plan that's saying, you know what, if it's between 2 to 4 days of service, we're going to look, and if we don't think it meets our severity index, we're going to pay you, we're going to treat it as an inpatient claim, but we're going to pay you at an observation rate, which essentially undermines the idea that if you meet the 2 midnight benchmark, it should be an inpatient claim. So we're seeing a lot of changes like this where I think there is some pressure, particularly with some of the risk adjustment activity on the Medicare Advantage side. There is a desire to show increased profitability maybe, and that's flowing down to providers.
I want to keep the conversation going to potential opportunities, but this is really important. We've just laid out the risks from the Medicaid side, the commercial side with OHCA, and the Medicare side. There's a lot of pressure that's just mounting on all of the payers, all the revenue streams that are expected to come for hospitals. And I would like to kind of think a little bit about some, if there's any positive news that did come out of HR1, Adam, I'd love to hear your take on maybe, I know this image isn't the best, right? Because it is crashing down on us, right, with the federal stuff. But, Rural Health Transformation Fund was one piece that did get added, and I'd love to hear your kind of thoughts on if that's our solution.
I was wondering where you were going about which positive news. So yes, and so there was money in the Rural Transformation Fund, and I think that it's a mixed bag because the governor's office is tasked with submitting proposals, and so every state is kind of going about that process differently. In California, it's the Office of Healthcare Information or Access and Information that has sort of been tasked by the governor's office to develop the application, and that's now been submitted to CMS. Based on what we were hearing from CMS. The conversation really shifted from, hey, the BBB is going to hurt hospitals, so we need to put something in there to kind of shore up rural hospitals in order to kind of rally votes for BBB passage. Where CMS ended up going with that program, though, was very, very different. A lot more interest in technology, in maternity health, and about kind of transforming, the healthcare system. Not exactly as helpful and direct when it comes to just sort of keeping hospitals' doors open and stabilizing the system, particularly with the payment reductions that are included in the bill. Regardless, through our work with the folks at OSHPD and some of the consultants that they were using to develop the proposal, we were able to successfully get something into California's proposal that is, related to kind of stabilization payments. And what's really unknown right now is how much of that sort of total pot that's available will go to some of those payments. And, the thing about, a lot of proposals in this administration is that there's an interest in making a lot of people happy. And I think that that's what the California proposal really is that I want to say there's like 24 different proposals in the Rural Transformation Grant Program. We don't know how much CMS is going to fund California's request. And then once it does, you then have to think about, well, how will the state sort of distribute the money among all of these kind of like 24 different, buckets that they've identified. So, kind of taking a good news story that, we were able to influence the proposal. There are some really good things in there. There is some interesting work that they're envisioning with hub and spoke models. We think that hospitals will have, an important seat at the table, assuming that some of that, does get funded in a meaningful way. I think that the downside is that this was not sort of the lifeline that was envisioned when the BBB passed. And, based on kind of the proclivities of this administration, there is this sort of approach of, we're going to do lots of little things and it's going to, we're going to transform things. And I think that it, makes for a good press release. It doesn't always end up in real transformation because there won't kind of be a pack a punch in any one area likely to make significant change. But I don't want to be too negative on it because there is a lot of good stuff in the proposal, and we'll just have to see how much California gets and kind of how the state ends up figuring out that prioritization, because that's what we don't have a good sense of yet.
we won't know for a little bit. But yeah, Eric, please.
Yeah, I would say what I hear primarily from a lot of the rural providers is just the overall concern that the additional investment for the transformation kind of projects that they're hearing is coming at the same time as obvious revenue reductions. And so the two together are making the idea or the commitment to the type of transformation that is called for here extremely difficult. And so in a lot of our areas, when they're looking at their long-term financial plans, they're really still wondering how this is all going to come together. So they're focusing, a lot on that advocacy plan. It's not going to come through this rural transformation. There's still a gap here that needs to be filled.
Yeah, I mean, we're one of 50 states that all submitted applications for, so the devil will be in the details when HCAI, knock on wood, hopefully gets an approved plan in front of them. I know what was submitted was what was articulated to us was the reddest application possible.
Right.
So I don't know what that means, but we hope that we get our share of it since it is so discretionary. But keeping on maybe the operational side, Eric, if you can kind of expand a little bit on, what are you seeing not only just in rural communities, but what are strategies that they're actually deploying that are positive outcomes with maybe rev cycle management or other areas of kind of focus that is yielding a positive outcome?
I don't know if I'd call it a positive outcome, but I think that they're
Less negative.
less negative.
Yeah, okay.
So a number of the hospitals that I'm talking to have spent the last few months recognizing that there's going to be significant revenue constraint coming forward, and coming up with strategies around that is going to be critical. And so we've seen a commitment to revenue cycle to make sure that there's a lot more visibility as to what's going on in the rev cycle, that they're responding to issues with the plans faster, addressing denial issues, contract issues in a much more rapid approach, not letting these things fester, taking things from discussions with plans from individual claims to something more broader theme issues that they're having. We're seeing a collaboration between providers and plans to try to solve some of these problems and manage around this a lot better. And then we're seeing a real commitment to more organizational cost-focused issues, service line reviews, going in and identifying what services really need to be the priority, how to focus, how to dig into them and find opportunities for productivity, and developing relationships or organizational approaches that take more focus on the ambulatory side, getting the patients where they need to be, managing the cost from that framework. I mean, that's just a throw food at the wall type of approach, but every hospital's going to be in a different situation as it comes to this. There's a lot of different strategies that hospitals can be focusing on. I think the approach is making sure, number one, more than anything, is that this is a time of change. We haven't been here in a long time. Some people probably, we were talking about things here, the 10% cut, like I almost completely forgot about that. But at the time that was like hair on fire. Like, wait, what are you talking about? But the provider fee and the Affordable Care Act, they really filled a big void in a lot of our balance sheets, and to start getting some vulnerability in those programs is going to require hospitals to make some changes and start to focus on how they're going to affect that, and that really just comes down to the change management, make sure the whole organization's focused on what that change needs to be and executing on that.
And from the finance perspective especially, right? Every little detail is going to matter. Curious, Felicia, and your advice on maybe the board or the governance aspect.
I'm going to work off of Eric's
Go for
statement first, is that, going back to 2008 to 2010, I mean, talking about coalitions, that was, the first time I did a statewide Medi-Cal challenge. It's how I met Francisco Silva, who's speaking this afternoon, who was at the time at CMA. those relationships are going to be important both on the statewide level, like we saw with the coalition around Prop 35, but also on a local level. And that's one of the reasons why all of the leadership in this room has been so important, because we're not just talking hospitals, we're talking other provider types as well. And so those kinds of coalitions and figuring out how we coordinate together to fill those gaps is really important. We've been seeing that. For example, financing HCLOF or IGTs. We've been seeing cross-public agency collaborations for IGT payments. We've been seeing plan and provider collaborations to fund HCLOF, all of which should be reviewed by the council, I might say. But those are exciting because that's how we're going to be able to keep the wheels on in some situations. I think it's really important. One of the things that, going to the board question, is that really also looking at what you already have. A lot of organizations we work with have some savings. They've got investments, and figuring out how they preserve those. There's a lot of talk right now about, the stock market, and I don't know anything about crypto, but my husband just tells me he keeps losing money on it. But those kinds of investments, making sure you're shoring that up, whether it means that you need to look at your corporate structure and double down on a foundation strategy, is important as well. And then the last thing, and a nod to today's theme, and I was talking to Demetrios about this, is not just sitting in a room and doing all of this yourself, but telling our stories. The press, the legislature, the agencies, they have no idea what we're doing if we're not out there telling our stories. If we're not saying, you know what, we got denied 4 times for the same claim, and then they already had all the information they needed, and then they denied it as untimely. If folks aren't hearing those stories, they don't understand, and they're just going to think that hospitals or other providers are deep pockets. And so making sure that story gets out there is really important.
That's actually really, that was our 2009 message. Tell your story. Our hospitals need to tell their story, because right now, the story is hospitals are overpaid.
Yeah, I totally agree with that, by the way. I always thought that it's like building a house. Your proposal, if you have a logical proposal, that's the foundation. You kind of have to start with that, but you can't go and move into a foundation. You've got to then have the stories that sort of sell the proposal in Sacramento, and I think that's really, really critical.
So before we move to kind of Q&A, I just asked one last question. So in the next, facing all these risks that we've just outlined, in the next 6 months, especially kind of in the window, if you were to give advice to a CEO or CFO or anybody in the room, what would it be to help them get in a position where they can be better prepared for these changes? And maybe I'll start with Felicia first. How about that?
I would say double check what's going on with your commercial strategy. We've all had to tighten belts, and a lot of this happened during COVID when folks moved away from going into the hospital every day. But one of the areas that I've seen really start to get less invested in is rev cycle. And making sure that, there are hospitals I work with that are still sort of in that traditional everything over, a certain threshold. They're appealing all the time because it's not about that one claim. It's about the claim that comes after it, right? And being able to pursue it. Or if you're, for example, if you have RHCs or FQHCs, you get a rate setting. Maybe it's only worth $150,000, but you're going to get that same cut for the next 10 years until you do your next rate setting. And so making sure that you're pushing on that so that you're getting everything you're entitled to, I think is really important.
Yeah, I would agree with that. I'll start there just because I think transparency into your rev cycle is one of the most important things that I keep pressing. If you don't really have good analytics where you can actually see what's going on and see what's not coming in correctly,
right,
and then not allowing you to respond quickly to the different payers, I think that's a really good low-hanging fruit item to get. But I was in another one of these panels, and so one of the participants was asked this question and was really talking along the lines of leadership and pointing out how a number of people on leadership teams across the country have not been in this situation. the Affordable Care Act helped out a lot. These supplemental payments and Medicaid helped out a lot. It changed the environment. And so it's going to be important to make sure they understand what, when these resources get dwindled, how you have to change focus. And so just going back to coming up with a sound strategy on how you're going to do it and executing across your leadership team and making sure that everybody is fully engaged, I think is going to be critical.
I think that kind of thinking about this more from like the advocacy perspective is that, humans are really bad at kind of long-term planning, particularly in the middle of a crisis. And sometimes you have to kind of think about, well, how do I survive in the short term? And first of all, you've got to do that. You've got to kind of protect the core and survive in the short term. But I think that in order for us to come out of this in the long term, we can't just completely let go of kind of where we want to go. I think that taking part in these conversations and as a field, continuing to take part in these conversations and to continue to think about long-term planning and where we want to be in the future, and encouraging your colleagues who, are not here and are not as active in these conversations to continue to be active kind of through this crisis period is really, really important, because if we're not having these conversations, then we're not building the foundation that we need to be building to come out on the other end. A lot of these problems are being caused by government policy. And so this is not your day job. You guys are doing really important work of running hospitals and saving lives. But unfortunately, a lot of the stuff that we're dealing with in Sacramento and Washington, D.C. is making your jobs harder. And so trying to carve out some piece of your busy schedule to engage in these conversations is really important, because I think that's going to dictate how we come out the other side.
Can I just add something really quickly? Because one of the things that I've heard a lot is hospitals suggesting that they've been able to push out the Medicaid dish cuts, or they've been able to push out, some of these, like the physician fee stuff. Like they've been able to, yeah. And so and because some of this is coming after the midterms, I think there's a prevalent thought that these things are going to get pushed out, that a lot of this stuff is going to be out on the horizon. And I'd be interested in your thoughts on this. But I think there's a lot of work that advocacy can do, a lot of work that hospitals could do to shape what this looks like. But I think something's happening here. Like these cuts are coming.
Yeah.
And the dish cuts did come for a bit,
They
right?
did.
And so, and finally, they reversed them when the government reopened. But we have never been in a more uncertain time.
Yeah.
So I couldn't have said any better. Never been in a more uncertain time. We truly appreciate the insight, you three, but we want to open it up to questions from the audience. I know we have about 10 minutes.
All right, questions. Oh, there we go.
There's not a lot of smiles.
Yeah, I mean, Demetrius,
I told you guys are the good news bunch. Don't worry.
Uh-huh.
You're on my first.
You were sitting when you stood.
Well, I know it's hard to tell when I sit and when I stand because I'm not that tall.
I know that.
So thank you for all of the good news, because we've all been delivering really great news. So my question is, understanding that we're facing these ginormous cuts and we're having to rebase, and every time we're in a crisis, we're in a crisis. But I'm wondering if any of you have seen or are thinking about, now that we're kind of breaking the system, is there opportunity to reevaluate what the payment systems do look like, and whether we can begin looking at, shifting how incentives are organized for health systems as we kind of enter into this new era?
So I think the short answer is yes. I think that you never waste a good crisis. And this is a crisis. And unfortunately, I think it could get worse. We started off by talking about the state budget. Well, we're not in the state budget crisis yet. We've seen it coming now for a couple of years. We had some cuts last year. It could get a lot worse from here. And so I think about that from the government perspective, and now from our hospital perspective. We're spending a lot of time thinking about how to use this crisis that we're in and think through ideas. No idea is perfect. There are no silver bullets in all of this. But yeah, that thinking is happening. And I think that, as the situation on the ground changes, it'll open up opportunities to, think about what those opportunities are.
I would just say that the one point that can't be made enough, HR 1 was not a healthcare bill. It was a tax bill.
Yeah.
If there's a HR 2, that'll be the healthcare bill. And if that's the case, it's going to open up everything for discussion. So there's a lot that could change depending on who the stakeholders are. I mean, there's a lot of those people that were involved in HCAI on both sides aren't there anymore. So there's new voices, and so there's a lot on the table.
And I think we're seeing on both the Medicare and Medi-Cal perspective that the DRG systems have changed behavior to a certain extent, but maybe aren't necessarily living up to what folks may have hoped for. And so I think there will be, at some point, I think definitely, I'm hearing stuff on the federal side. Folks are starting to think through MSDRG and whether or not that gets us to where we want to be as a society and for the priorities under Medicare. And so, I think that's going to continue to shift and evolve as well.
Oh, thank you.
Hi. Wondering if you all are hearing that there are particular service lines that are particularly at risk right now. I think, there's the idea that hospitals close, but then there's also kind of the very real reality that they don't close, they just close certain service lines. And of course, I work on behavioral health, so worry a lot about the 80 or so psychiatric inpatient units that our general acute care hospitals have in California and their viability to stay open. Are you all hearing about that or other types of services that are really at risk right now?
I wouldn't say that there's one particular service line that has jumped out, but I've been involved with a number of organizations that are reviewing all of their service lines and prioritizing along those. But I've seen kind of a mixed bag based on the market itself and who's in the market and the decisions around that. A lot of them are very hard decisions.
I agree. I wasn't going to talk about this, but I think there was a significant change in Medi-Cal reimbursement for inpatient psych services for the Medi-Cal fee-for-service hospitals that there's now being implemented retroactive to December of 2023. And I think that's going to have a really significant impact potentially on some acute psych hospitals. And so I think that is one that we're going to be seeing a financial pressure before a lot of the other cuts come through because that's already being implemented.
Maybe I'll just add one thought too, since we so many of the district hospitals up and down the state, a lot of them serve rural areas. Kirsten, to your question, we've seen labor and delivery services actually be the first to go in many of those communities, but it's not just the response of the financial strains, it's the holistic challenges that are in those communities as well. Do they have the right staff? Do they have the right volumes, et cetera? So they are making those difficult decisions. We are also seeing, in light of these changes, these financial challenges that are on the horizon, many are pushing off those capital investments or rethinking what their future actually looks like in light of all these changes. So it may not be closure, but it sure as heck isn't expansion or it isn't, bringing on new service lines by any means. So that is a real challenge that we're all going to be faced with for some time. Thank you for your question.
Yep.
Hi, and thank you so much for this very, very informative and engaging discussion today. I come from a very large health center within a conglomerate of very large health centers. And in recent years, we have experienced very aggressive negotiation tactics from the large insurance companies. All the while, they have been posting billions of dollars of profits. At what point do you think they are going to become partners to us and realize that if the large health centers fail, they are going to lose their partners. So when do you think they are going to change their tactics, and when do you think or how they are going to become true partners to us?
Nose goes.
I'll start because I in the discussions I've had with the plans, there is an acknowledgement that the providers can't own this. Like their members have to go somewhere, and the hospitals can't close, and so there needs to be a collaboration here. Both sides are going to have to come down and work together and come up with solutions along that. Now, this is the opportunity. I mean, we have a crisis. What was your quote? Never waste a good
Never waste a good crisis.
And so maybe that is the impetus to finally get the plans to sit down and have those type of discussions and have that type of collaboration. I think maybe if there is more federal and state efforts to push that together, that might actually make it happen as well. And I would say that that's just based on some of the policy talk I've heard is definitely on the landscape.
Great question.
Yeah.
I know all crystal balls are fuzzy, but if you had to think about where the system, our healthcare system in California what it might look like in 10 years or so, are there one or two things that you think are likely to occur? Or are we like the frog getting slowly boiled as the temperature keeps rising?
Please.
So I'll start, and it might be speaking out of turn, so the folks in Sacramento who don't like this idea can shoot me now. But I think one of the things we really need to look at is how expensive it is to render hospital care, whether it's HCAI requirements, whether it's CDPH, whether there are a lot of different requirements that are being imposed. I know that when Doctors Medical Center of San Pablo closed, there was a discussion of being able to convert it into a freestanding emergency department, which has been championed in other places in the country. It may be possible that we need to start looking at alternative ways of providing services while trying to retain that safety net. And especially, we talked about hub and spoke. What we're doing in the Central Valley. I think we're going to have to be real creative around some of that stuff.
Thinking about this, why do you not waste a crisis? Because there are things that people are unwilling to do during normal times that all of a sudden, become more rational when the world is falling down around you. And, one of the things that we've been talking about for next year is sort of the state's not going to have a lot of money. We're in a lot of trouble. We're trying to stabilize the system. Is there regulatory relief? We're going to have a new governor coming in. What kind of things can we do that don't cost the state a lot of money, that would be unthinkable during sort of normal times? A lot of the things that are done out of like the best of intentions. They're done to protect people. They're done to improve quality, but they drive up costs. And so things that are unthinkable during normal times might be possible. And so what can we actually get done in this environment going, in the short term, I think is something that we're thinking about there.
Maybe one comment, and then I will see if Erica has a comment too. But the way we have financed Medicaid over the years, the last 20 years in particular, it's gotten the state off the hook.
Yeah.
Right. So if we start to think through 10 years from now, the levers that we have had and we've deployed to expand Medicaid coverage to all, right? The ACA, the implementation of the Affordable Care Act, there is going to have to be a tide that turns where the state's going to have to actually step up and make those contributions. And so much of that cloudy picture is how willing are they to jump into that fold, right? Where we've all, helped alleviate the burden that's been placed on them. where we don't have that tool anymore, right? Or it'll be restricted or limited. And so I think that is going to be really the first domino to fall. And the structural deficit is not adding a lot of confidence that they're going to be in that position to do that. So,
But when we do it and how we do it
Yep.
makes a big difference. And
Yep.
so, I think Ryan's absolutely right. The devil will be in the details of how we get there.
thank you for your question. And thank you all for weathering 90 minutes of enjoyment. Thanks to the panel.